Hello everyone, welcome to our new topic of discussion, that is on hypertension in diabetes mellitus, which is a macrovascular complication of diabetes mellitus. Hypertension in diabetes is a common comorbid condition, and this can significantly contribute to mortality and morbidity in a patient of diabetes. Apart from that, it can also increase the cost of treatment in any patient with diabetes. Hypertension in diabetes is a major risk factor for microvascular as well as macrovascular complications in diabetes, as it increases the risk of cardiovascular diseases in diabetes. Let's see the definition of hypertension in diabetes. So, whenever there is sustained elevation of blood pressure, that is at or above 140/90 mmHg, then we are confirmed that the person is having hypertension. But this recording should be during the separate clinical visits, not a single recording. Hypertension can occur in any kind of diabetes, that is type 1, type 2, even it can be present in a person with pre-diabetes also, and the prevalence of hypertension is found to be around 1.5 to 2 times greater in a patient with diabetes as compared to the normal person. So what are the significance of having hypertension in diabetes? Hypertension in diabetes can enhance the progression of microvascular complications. It can also accelerate the mechanism or process of development of atherosclerosis, which may result in myocardial infarction, angina, and acute coronary events. Apart from that, this hypertension in diabetes can also accelerate the development of other revascularization events, which include TIA, transient ischemic attack, stroke, and peripheral vascular diseases. And having these complications, prevalence of hypertension is found to be as high as 30%, particularly in the urban areas. The patient with diabetes also follows the rules of SHAPS in respect of hypertension in India. Now, let's discuss what are the associations between the hypertension and diabetes. Hypertension is an important correlate of the metabolic syndrome or syndrome X. Metabolic syndrome or syndrome X are the clusters of the risk factors. If all these risk factors are found together, so they can result in development of few complications, metabolic complications, syndromes, which are hypertension, diabetes mellitus, stroke. So this hypertension in diabetes can also result in risk of cardiovascular diseases. It has been suggested that whenever there is a condition of hyperinsulinemia in patient or in individual with insulin resistance, then it can also lead to development of hypertension. This high level of insulin can affect the kidney's response to its enzyme, that is angiotensin 2, and this inappropriate response of angiotensin 2 can lead to retention of sodium and water from the kidney, leading to volume expansion and ultimately causing the increase in the blood pressure level. There are few endocrine disorders which are associated with hypertension as well as the glucose intolerance. They are acromegaly, Cushing syndrome, Conn's syndrome, pheochromocytoma. It has been found that in individuals with diabetes, the hypertension can arise in various other ways, as we have discussed that the hypertension can be associated with diabetes as a part of syndrome X or metabolic syndrome. Hypertension can also be associated with a patient with nephropathy, and this nephropathy is very common in type 1 diabetes mellitus. Hypertension can be present in a patient of diabetes as a coincidence. Few examples are essential hypertension, the isolated systolic hypertension, renal scarring from recurrent pyelonephritis. It can be also be seen as autonomic neuropathy, in which the person will have hypertension in supine position with orthostatic hypotension. There are few drugs which cause both this metabolic complication, hypertension as well as glucose intolerance. If any person is having glucocorticoids, then he can also develop hypertension in a patient with diabetes. The combined oral contraceptives have also been seen associated with development of hypertension in the patient with diabetes mellitus. Now let's discuss about the staging of hypertension in diabetes. So if the systolic BP is less than 120 mmHg and diastolic is less than 80 mmHg, then this condition, the person is labeled to be as normal. The BP will be labeled as elevated when the systolic BP comes between 120 to 129 and the diastolic BP is less than 80 mmHg. The stage 1 hypertension will be labeled when the systolic BP is between 130 to 139 and the diastolic BP comes between 80 to 89 of mmHg. Stage 2 hypertension will be said when the BP level is, the systolic BP level is more than or equal to 140 and the diastolic is more than or equal to 90 mmHg. Hypertension crisis will be labeled when the systolic BP is more than 180 mmHg and or diastolic, either of two, diastolic BP is more than 120 mmHg. The systolic BP of more than 140 mmHg is considered to be an important risk factor for having cardiovascular diseases, and it is more important as compared to the diastolic BP. If the increment of BP is 20 by 10 mmHg, 20 in systolic BP and 10 in diastolic BP, after recording BP at 115 by 75 mmHg, then the risk of development of cardiovascular diseases are doubled. If the BP rises more than 20 by 10 mmHg, means 20 in systolic and 10 in diastolic, above the goal BP, and the goal or target BP is considered to be 140 by 90 mmHg, then in that condition we need to initiate the therapy of the person with two agents of antihypertension. There is a phenomena which is known as white coat hypertension, and this phenomena should be ruled out before we are labeling any person of having hypertension. As per this white coat hypertension, which is also known as white coat syndrome or white coat effect, then this white coat hypertension is a medical phenomena in which the person's blood pressure recordings comes consistently higher. When measured the blood pressure in a medical setting like any doctor's office or any doctor's clinic or hospital, as compared to the BP recordings which have been done in outside of that medical environment, such as home or any relaxing setting. The reason behind this white coat hypertension are due to anxiety, fear or nervousness that are associated with being in a clinical setting or being examined by a healthcare provider. So this white coat hypertension can lead to misdiagnosis of the person and unnecessary treatment or medication of the person. Now let's discuss what are the risk factors of hypertension in diabetes mellitus. So development of hypertension in diabetes depends on the type of diabetes, the duration of diabetes in person, the age and gender of the person, the presence of any microvascular complications in the person, such as presence of renal disease, the race and ethnicity of the person, the body mass index BMI, based on which we label any person as overweight or obese, is also an important risk factor for development of hypertension. Apart from that, the inappropriate glycemic control is also a major risk factor for development of hypertension in a patient with diabetes. Now let's discuss the screening of hypertension in diabetes mellitus. So whenever any patient with diabetes comes to us, so we should always consider for the monitoring of blood pressure in such person in each routine clinical visit. If any person with diabetes or pre-diabetes comes to us who is obese or overweight, then always we should test such person for hypertension by recording BP. The goal BP in such person should be less than 130 by 80 mmHg, and if any person develops blood pressure beyond the 130 by 80 mmHg, then we should immediately consider for initiating antihypertensive therapy, which will reduce the risk of development of cardiovascular diseases in such person, and this will also reduce the risk of development of any microvascular complications. Now let's discuss the diagnosis of hypertension in diabetes mellitus. So the hypertension in diabetes is defined when the BP is more than 140 by 90 mmHg, and this 140 by 90 mmHg of recording should be taken on the multiple recordings on the same day, and this more than 140 by 90 mm of Hg of the BP recording should be also done on the different days within a month. Whenever we are recording the BP, we should take average of 2 or 3 recordings at 2 to 3 minutes of interval. We should also consider that the BP recording should be done in both the arms, not in a single arm. Now let's discuss about one of the phenomena which is known as orthostatic hypotension. This is also called as postural hypotension. Orthostatic hypotension or postural hypotension is a form of low BP, low recording of blood pressure, that happens when person stands from a sitting or lying down posture, and this reduction or low BP is recorded within 3 minutes of standing from the sitting or lying down posture. The orthostatic hypotension is finally diagnosed or labeled when the reduction in the BP is more than 20 mmHg in systolic BP, and the reduction of BP is more than 10 mmHg in diastolic BP. The orthostatic hypotension is caused by arterial stenosis. The arterial stenosis occurs when there is a narrowing of the aortic valve, the heart, and because of this narrowing of the aortic valve, there is compromise of the flow of the blood, which ultimately develops the orthostatic hypotension. And for diagnosis of orthostatic hypotension, we should always record the BP on both the arms in the first visit. Now let's discuss the management of hypertension in diabetes mellitus. So we will cover this topic, the management of hypertension, in 3 headings: the treatment goals and strategies, precautions to be taken, and the special considerations. Now let's cover the first heading of this management, the treatment goals and strategies. So our goal of treatment in a patient with hypertension should be to maintain the BP below 140 by 90 mm of Hg. This BP below 140 by 90 mm Hg will definitely reduce the cardiovascular events as well as the microvascular complications. If we are maintaining the BP below 130 by 80 mmHg, then it reduces the risk of atherosclerotic heart disease. If the BP is maintained below 120 by 80 mmHg, so it has been seen that it will significantly reduce the incidence of stroke in a patient with diabetes. The treatment strategies in a patient with diabetes includes the lifestyle management and pharmacotherapy. So now let's see the lifestyle management. The lifestyle management in a patient of hypertension, in a patient with diabetes, includes the reduction in the weight if person is overweight or obese, the restriction of the consumption of alcohol, which is also a contributor for development of hypertension, the increase in the physical activity or reduction in the sedentary lifestyle. The lifestyle management also includes the follow of DASH style dietary pattern. This includes the restriction of the intake of sodium to less than 2300 mg per day, the consumption of 8 to 10 servings of fruits and vegetables per day, and consumption of 2 to 3 servings of low fat dairy products per day. Now coming to the pharmacotherapy. The pharmacotherapy is considered to be an essential strategy in addition to the lifestyle management which we have discussed in the previous slide. For treatment of hypertension in diabetes, there are various different classes of drugs have been recommended, which includes the angiotensin converting enzymes inhibitor, ACE inhibitors, angiotensin receptor blockers, ARBs, thiazide diuretics, and calcium channel blockers. The ACE inhibitors and ARBs are considered to be the first line of treatment in a patient with hypertension in diabetes mellitus when the BP is above 140 by 90 mmHg and the urinary albumin creatinine ratio UACR is more than 300 mg per gram of creatinine. The advantage of using ACE inhibitors and ARBs are that these drugs prevent the progression of renal disease as well as they also reduce the risk of development of cardiovascular diseases. So what are the drug regimen for treatment of hypertension? Whenever the BP is between 140 by 90 mmHg to 150 by 99 mmHg, then we should consider for single drug therapy. If BP is above 160 by 100 mmHg, then we should consider for two drug therapy. If the BP is persistently above the 160 by 100 mmHg in spite of two drug therapy, then we should consider for three drug therapy in such patients. When there is resistant hypertension is present, then we should consider for the 4 drug therapy. The resistant hypertension is defined when the blood pressure remains above the goal blood pressure despite concurrent use of 3 antihypertensive drugs, and out of these 3 drugs, one of the antihypertension drugs should be diuretics. Now let's discuss what precautions we should take while doing the drug therapy. So the ACE inhibitors and ARBs, angiotensin receptor blockers, should not be combined together. They should always used separately, because if we are combining these two drugs, it can lead to development of hyperkalemia, syncope, and it can also cause the acute kidney injury. Whenever we are starting therapy for the hypertension, we should always titrate the dosage of the drugs. If any person is taking drug therapy for hypertension, we should monitor annually the levels of serum creatinine, the EGFR, and serum potassium. If any person is taking treatment for the orthostatic hypotension, in that condition we should take important precautions in respect of adjustment of the dosage of the drugs, and we should stop the diuretics in such persons. So what are the factors which influence the drug therapy? So before starting intensive control therapy for hypertension, we should always considered about the few factors in mind. They are the level and staging of hypertension in the person, the age of the person with hypertension, and presence of any microvascular complications in such patient or person. Now let's discuss the phenomena which is known as resistant hypertension. So this resistant hypertension is a condition when if a patient is on 3 drug regimen of antihypertensive drugs for treatment of hypertension along with the lifestyle management, but still the BP of such person continues to come above 140 by 90 mmHg, then this will be labeled as resistant hypertension. So what are the treatment methods for resistant hypertension? So in this condition we will use the 4 drug regimen, which will include the ACE inhibitors or ARBs, either of them, the calcium channel blockers, diuretics, and mineralocorticoid receptor antagonist. But the addition of these 4 drugs causes increase in the risk of hyperkalemia. So whenever we are treating for any resistant hypertension and you are using 4 drug regimen, we should always monitor the serum potassium level regularly. Now let's discuss the antihypertensive therapy in pregnancy. The drug therapy is not recommended in pregnant women if BP is below 160 by 110 mmHg. The target BP or goal BP in pregnancy should be between 120 by 80 mmHg to 160 to 105 mmHg, and the lower target of BP should be considered in patient if the patient is with an organ disease and with cardiovascular disease. Now see what are the recommended drugs and what are the contraindicated drugs in pregnancy. So in pregnancy the recommended drugs are methyldopa, labetalol, nifedipine, and hydralazine for acute management. And the drugs contraindicated in pregnancy are ACE inhibitors, the ARBs, angiotensin receptor blockers, and spironolactones. The cardiovascular events in pregnancy can be reduced if we maintain the BP below 140 by 90 mmHg. If we have come to the end of this video, please like and share this video with others.